Yeah. Um, cool. All right. All right, we are live. So I haven't checked the weather, but that's usually something I start with because everybody pokes fun at sunny Southern California.
Yeah.
So what are you doing? What are you guys pushing in? You're in Minneapolis, right?
Yeah, Minneapolis, St. Paul. We had a good evening today. So we were in the 60s, I'll say. And it's going to dip down into the 30s or 40s tonight, which is, colder than we like. But we're past the worst of the winter, which is we're happy in Minnesota when that happens.
Fair.
Sure. Yeah.
I will say 30 or 40 degrees, that's like open window weather for me.
Oh, really?
I'm a polar bear, so I'm the one that
wow.
goes in. When I check into a hotel room, I hit the down arrow until the AC stops. Most hotels it's 65, sometimes it's 62.
Wow.
Yeah. I like it just above where your joints feel like they're stiff. That's my personal comfort zone.
I think
everybody who wears jackets, I don't get it.
Yeah. I think we'll have to have a talk about good sleep hygiene temperatures after this, maybe.
Yeah. Yes. Yeah, I love sleeping cold.
Sounds like you take the advice of a cool bedroom to the extreme.
Yes, I do. I actually, my wife is the cold one. I'm the hot one. I've always kind of pushed on the let's get it colder. And now that we've got 4 kiddos who all like it cold in the bedroom, I have the quiet majority.
Yeah.
So yeah.
That's funny.
Yeah, I don't know. I like it. Well, we've been like 90 degrees the last week here.
Oh, wow.
And we are not happy that summer's early. And then it cycles down and it rains once in a while. But anytime you complain about the weather in Southern California, nobody takes you seriously.
Exactly. Yeah. Stop
so
it, right?
why? Yeah. So just stop.
Yeah. I mean, the commonest question I get is like, what made you move to Minnesota of all places? And it's sort of like everybody is like, it's freezing. Why would you do it to yourself?
Well, I mean, you get to fill a coffee cup with hot water, throw it in the air in the middle of the winter, and it turns to ice. There's that.
There's that.
Yeah. I actually flew out in the polar vortex a week after the polar vortex a couple of years ago.
Oh, wow.
I was, for the first time in my life, introduced to negative 34 degree weather without the wind chill. And I was like, yeah, if my car breaks down, I'm dead. That's a really unnerving thing to think about.
When Minnesota is actually not the coldest place I've been, believe it or not. So about 4 years ago, I was in Kazakhstan doing a lecture for a cardiologist, believe it or not. And when we landed, it was minus 40. So that was yes, again, without the wind. So
holy smokes.
Yeah.
I didn't know that de-icing fluid freezes at negative 27 degrees or something like that. I thought this is I had a flight delay because the de-icing fluid was frozen for the plane.
Right. There's some things you really don't want to experience and know, probably.
No, not at all. Well, we're 1 minute after the hour. So I do want to welcome everybody here, respect everybody's time that is on our webinar tonight. We got somebody already representing. We got somebody from Winnipeg, Canada saying hello. So I think Barry, you are probably laughing your head off at me. But here in Southern California complaining about the weather. William from Mississippi. Yeah. Hey guys, well, since you're here, why don't you shout out, tell us where you're from. We'd love to see that in the chat. We're gonna have some fun tonight talking about telemedicine, how it relates to dental sleep medicine, and We've got the amazing and infamous Dr. Jagdeep Bijwadia. I know he'll probably shake his head at some of my my compliments here, but just to give you guys a quick bio on Dr. Bijwadia, he is the founder and CEO of SleepMedRx. He also serves as a chief medical officer for a couple of companies, WholeU and Better. He's triple board certified in internal medicine, pulmonary medicine, and sleep medicine. And prior to starting his own practice in Minnesota, he served as attending physician at Health Partners Medical Group, where he was the department head and the director of the Sleep Medicine Center. He currently holds faculty position as assistant professor in the Department of Pulmonary Critical Care and Sleep Medicine at the University of Minnesota, where he serves as the director of the sleep program until 2012. He also, in his spare time, completed the executive MBA program at the University of St. Thomas in Minneapolis. He's been named top doc by the Minneapolis Magazine, as well as US News and World Report. And he is the past president of the Minnesota Sleep Society. He is actively promoting positive sleep health across the state of Minnesota and the United States. And I have to say, Doc, you have amassed quite a following of colleagues and raving fans for your telemedicine solution. So
well, thank you.
We are truly looking forward to the content tonight. I do know you've got slides, and I don't want to stay in the way of those. Sure. Is there anything that you want to add that I missed? Because I'm just the announcer here.
No, that's great, Michael, and thanks for that kind introduction. It seems like a long time ago when I started out, in dental sleep, and I don't know whether I ever told you the story, but I actually am a CPAP failure. So I have REM-related sleep apnea, and many, many years ago, tried CPAP, couldn't tolerate it. And being a sleep doc, it's almost like a failure, right? You feel, bad that here you are preaching and, but I was looking for alternatives and found somebody that was in Minnesota at the time, Dr. Murarasu, who was board certified in sleep and got a dental device and never looked back. So, I think, I certainly am a believer in oral appliances. I've been, associated with SomnoMed for many years as chief medical officer now at Respire. So I have a deep sort of appreciation for the dental field. I've talked and, worked with so many prominent KOL dentists. And really, I feel the pain that dentists sometimes go through, both getting into the field and trying to get referrals from sleep physicians that just, may be skeptical. And I think that it's fair to say that, the whole point of SleepMedRx for me was to really reduce barriers for patients. And obviously telemedicine allowed me to sort of catapult that to a new level. But I honestly feel that, the way to success is collaboration and also an appreciation of patient preference. So yeah, I'm excited to be here. Absolutely.
That's awesome. Yeah. How long ago did you get your appliance? Out of curiosity.
This was in 2004. So quite a while ago.
Wow. Yeah, a little bit ago. So you're one of a long-term compliant patient, helping those numbers out on the oral appliance side.
Yeah.
Cool.
And I haven't had too many side effects, so we're good to go.
That's awesome. Well, before we do get going here on the slides and the content, this is a CE event, guys. So we do want to just give you a couple of disclaimers, disclosures. So the webinar tonight is hosted by Awaken to Sleep and SleepMedRx. I am the CEO founder here at Awaken to Sleep. We help dentists do better work in dental sleep medicine. Dr. Jagdeep is the CEO of SleepMedRx. So he is facilitating those telemedicine consults. Outside of that, the standard stuff. You all have been on CE courses before. There's going to be a survey link posted in the chat at the end of the webinar tonight. We can do that at the earliest at the 55-minute mark, so we'll do it as soon as we can. If you click the link, it's going to take you to a survey that will take you exactly 37.2 seconds to complete. It's incredibly long. Just kidding. It's really short, succinct, won't take a lot of your time. Please fill that out. It will auto-generate your CE certificate. If you miss the link in the chat for some reason, that's okay. We're going to send you an email tonight. It will get to you by 7 o'clock Pacific time. If you don't have an email in your inbox by 7 o'clock Pacific, it's in your spam. Please check that before you go dig up a support link ticket. We would super appreciate that. The other thing is, guys, we want to enjoy the time together tonight. If you've got questions, we are here for you. So please post them in the Q&A. We will try to keep the chat for any tech support issues or answering any of Dr. Bijwadia's questions as he's going through this tonight. So hang on, we got a lot of content to get through, and let us know if you got questions. We're here for you. Doc, it's all yours.
Thanks, Michael. Hi, everyone. Appreciate you joining the webinar, and hopefully we'll get some interesting information across. Just as a little bit of background, what I'm going to do is, start with some really broad strokes about telehealth and telemedicine and what it is and how it evolved, maybe just a few short things. We'll talk about some of the barriers and regulations that one has to sort of navigate as one does telemedicine, which is important for all of you from a regulatory standpoint as you start working with maybe other companies as well that do telemedicine. We're going to dive down a little bit into what are the types of things that we can do with telemedicine, and sleep. I think sleep is a specialty that's especially suited to telemedicine, and we'll learn about some of the sort of studies that have been done that validate that. And then the last several slides will be focused more on dental sleep medicine. Like, what does telemedicine give to a dentist that wants to do sleep medicine in particular and sleep apnea specifically? And how does that improve the patient journey and reduce barriers? And what is the best way to use telemedicine? And I think that over the last 2 or 3 years, we've certainly learned a lot that hopefully I'll be able to share some. So, telemedicine is not a new concept, right? Right back in 1924, there were, at least these visions of, being able to treat patients remotely, possibly with robotic fingers on surgery. And it was more of a fantasy at that time. But not so long ago, in 1959 to 64, in that range, there was the first actual interactive video link between the Nebraska Psychiatric Institute and the Norfolk Hospital. And this, they actually provided care across a chasm of about 100 miles. That was followed very soon in the 1900s, again, when NASA took on telemedicine. And this was the, space age, push telemedicine, just as, and we'll talk a little bit about how COVID has had another, huge jump for telemedicine. But that is where they were trying to figure out, how do we deliver healthcare to astronauts, and how do we use the telecommunications technology in that particular arena. And then as you look through the 1970s and the mid 1970s, that particular space technology now starts really in earnest, where people are now saying, hey, let's use telemedicine to get to rural areas like the Indian Health Services. And there was a very large government-sponsored program in Arizona, in the Indian reservation. And they actually did things like x-rays that were read remotely. In 1989, it was the first time a patient was successfully defibrillated by telemedicine. So 1993 was a landmark year, and that's when the American Telemedicine Association was formed. It's a nonprofit association, and if any one of you ever wants to have sort of a deep dive into telemedicine, their website is excellent, as well as the Centers for Connected Healthcare. Really great fund of information in both of those. But as we go further, certainly in 2020 now, it's become a huge industry. And I think it's important for us to sort of just, quickly get some definitions out of the way. So what is the difference between telehealth and telemedicine? So telehealth really is just using technology for any sort of health application. That could be public health, health education, any sort of telecommunications technology. And how I like to sort of define it is using technology for anyone doing anything, and any technology. It could be a telephone, it could be a computer. So as long as you're using technology in some healthcare space, that would be defined as telehealth. Very, very broad. Now, telemedicine, though, refers specifically to clinical services. So when we're doing X-ray reads or doing consults, that is specifically what telemedicine is. And is it effective? I think that as I look back, if you think about disruptive technologies, right? If you think about streaming audio, or if you think about cassettes going to CDs and then going to streaming audio, there's always this time period where a new technology has to get legs and has to get acceptance. So just because the technology is available doesn't mean it's going to be accepted. But if you think about telemedicine, right now, about 74% of millennials actually prefer telehealth. 89% are accepting telemedicine as sufficient, and 85% are satisfied with the care from telemedicine. I can tell you in my own practice, and admittedly, I'm a big advocate for telemedicine, but I always offer my patients at the end of the visit with us, would you like your next visit as a telemedicine consult, or would you like to come in? And I would say 60 to 70% of patients for sure say, hey, you mean I can do it from home? Absolutely, let's go there. So on the clinician side, of course, 93% now view telemedicine as acceptable, which is a change. I mean, there was always this idea that, well, can you really do a physical exam on, using telehealth? And the answer today is that most physicians believe that you can offer very effective equivalent care with telemedicine, especially with sleep. It's also extremely cost effective, right? There have been lots of studies that show that there's a significant cost savings. So for example, here's just a couple of examples. So in Philadelphia, Jefferson County, telemedicine, they reduced the cost from $1,500 to $300 for a visit to the hospital, and $120 to $19 per telehealth visit. So we think that telehealth is projected to save over $300 billion annually. So there's certainly a strong economic argument to be made for getting telemedicine in place. And you can see here that one of the biggest changes that's happened is COVID-19, right? By necessity, we had to use COVID. Not only because it was not possible to see patients in person, that was one thing, but also it allowed physicians especially critical care physicians, to deliver care to multiple hospitals simultaneously, right? So critical care was very significant. In the field of sleep, in-lab polysomnography was almost dead in the first 2 or 3 months of the COVID crisis. You can see here in the European data that in the first 6 weeks, the in-lab polysomnography went from 92.5% to 20%. And you can see right across the board, I mean, home sleep apnea testing, and in Europe, they actually do it in person, where they actually fit the patients with their home sleep test device. So everything fell. So COVID was a huge jolt to the system, right? And everybody was sort of panicking because patient volume decreased by 41% across all clinical specialties. And providers very quickly had to adopt and learn telemedicine. And if you look at the Medicare data, telemedicine use exploded 175 times what it used to be in terms of the previous year. And $250 billion of US healthcare spending was felt to come from virtual medicine. So I think that although telemedicine has always been present through the years, the technology certainly has advanced, and the necessity that was created by COVID has really jump-started this. And it's an opportunity for us to be able to reach more patients in an extremely efficient manner. And I think specifically for dental sleep medicine, you will see how this can actually change the way sleep medicine is practiced in your own office. Obviously, there's a lot of telehealth companies that's whose stocks have just skyrocketed, right, because of the COVID, after COVID. And you can see here the global telemedicine market is expected to grow at a CAGR of about 19.2%, which is astronomical. Very, very few industries have that sort of compound annual growth rates. And you can see here that the adult US health use has increased as well. So today, there's about 30% of elderly patients who have never used telehealth, which was the opposite prior to the COVID epidemic, where it was 30% had used it. You can see here that companies like Livongo that offer virtual diabetic care and iRhythm that do cardiac monitoring remotely, their stocks you can see here right about March, which is when the COVID crisis starts. You can see this astronomical rise, right, in both of their valuations. Again, a reflection of how telehealth is really taking on. Another example here is where Teladoc, probably the largest telehealth company in the world right now, has more than 12,000 clients, 51 million members. Teladoc operates in 175 countries and has about 4 times utilization over the industry average. So just incredible numbers just in the past year or two. So there is a very, very significant opportunity. And if you pause and think for a minute about, why is telemedicine taken off so much? Certainly COVID, we've talked about that, but it really creates value for payers, for consumers and providers. We'll talk about how payers really were very reluctant to take on telemedicine. And part of the reason was they thought it would actually escalate costs, right? Because now it's so easy for a patient to get online. Let's be careful. So if you think about the United and Aetna's and Blue Cross Blue Shield, you'd like to think they have patient welfare in mind, but I certainly think cost is very much on their radar screen. And so they were pretty reluctant to use telemedicine. Certainly increases consumer access. So if you, in your own practices, if you wanted to see a sleep doctor, you probably had to think about, who's in your vicinity, who's oral appliance friendly, can you create those relationships? It was a hurdle, right? But now with telemedicine, we have companies like SleepMedRx that are actually focused on providing that care to patients and taking patient preference into account. And I can certainly tell you that for SleepMedRx, we definitely feel that oral appliances should be the first-line therapy for mild to moderate sleep apnea, especially when patients, prefer it. So we're very strong advocates for that. Telemedicine also allows an enhanced reach for healthcare services. So if you happen to be in a smaller town or a rural area where you might not have as much access to sleep physicians or working collaboratively, that barrier is pretty much gone now. Certainly reduced cost structure. We have probably telemedicine today with our company costs a fraction of what it would to go through insurance and the costs involved with that. And I can tell you that our customers are extremely satisfied, whether you talk to the dentists that use us or the patients. And that goes across the board for telemedicine. I think most people have a very positive experience. And as I mentioned, in a way we're lucky because with sleep medicine, our physical exam is fairly limited, right? You have the patient open their mouth, look at the back of the airway, and you can do that very effectively through telemedicine. So when the COVID-19 epidemic hit, the American Academy of Sleep Medicine had to really scramble, right? And they said, well, how are we going to keep our sleep labs open? And they had, a variety of guidelines that they set out to have. And I think it's fair to say that at least for the first 3 to 6 months of the pandemic, most of the sleep labs were not doing any testing at all. And then finally, when they did start, there was a very significant concern about the aerosolization of particles from CPAP and BiPAP. And so most labs, when they did open finally, did diagnostic testing, but titrations, pretty much were few and far between, and the use of auto CPAP and other modalities started increasing. So there was definitely a change in how sleep medicine was practiced, even in the offices. But I think one of the biggest positives came from the government. And the government realized that, look, if we don't embrace telemedicine, we're going to be in trouble. Obviously, it keeps the patients and the physicians safe because there's obviously no spread of COVID through that, and increases the reach. So what CMS did in a landmark move was they said, okay, we're going to pay for telemedicine visits on par with a patient in-person visit. That was a sea change. So no other payer was doing that. But once CMS did that, all of the payers obviously followed. The other thing they did was they waived geographic restrictions. So what CMS said prior to the COVID pandemic was that if you wanted to see a patient using telemedicine, they had to be in a geographically underserved area, like rural areas or things. But they waived that geographic restriction so that once, after March 2020, in the Twin Cities, I could see somebody right in the next suburb through telemedicine because that restriction was lifted. All in all, they added about 104 services that could be provided by telemedicine, including physical therapy, nursing, just a whole bunch of different providers. They also relaxed interstate licensure requirements. So, and we'll get into a little bit about how the regulations work around telemedicine, because they still, that is still a factor that we have to deal with. And they also relaxed HIPAA requirements. So in the past, you had to have, there were extremely stringent privacy laws. And for example, you couldn't see a patient on FaceTime or Skype, right? But with the advent of the COVID crisis, they realized that they had to relax some of those rules. So they relaxed those HIPAA requirements. And I think the questions that will remain is, what will happen to these payments in the long term? So, we know now that there's parity, right? You can get paid by insurance companies the same as you would in person, but will that be the same in 2022, in 24, for example? Not 100% certain, but I think most people feel that the cat's out of the bag. I mean, it would be really hard to put the genie back in the bottle in terms of telemedicine, because patients really have enjoyed the convenience of this. And then there is some question about disparities. So if we're going to be expanding telehealth and telemedicine, how are we going to address the minority communities, rural health? So there has to be some work done in that area as well. I think that when we think about telemedicine, there's really three kinds of telemedicine that you need to know about. One is what's called asynchronous or store-forward telemedicine. This applies to areas like pathology, dermatology, radiology, where they get data in real time, but then a doctor would review the data and generate reports maybe a few days later, and give the patient back the report. The telemedicine that we're most used to is actually synchronous telemedicine, right? This is what we do when we see patients online and do their consultations. And that's called synchronous telemedicine. And lastly, there's this new advent of remote patient monitoring, where once you've seen a patient, you can maybe monitor their compliance or their response to therapy. For example, if you're a diabetic or a congestive heart failure patient, your doctor could be gathering data using technology, whether it be wearables or home sleep testing devices, whether that be glucose monitoring or cardiograms, and they can actually take care of the patients on a team basis. That's called remote patient monitoring, and it hasn't, it's starting to take off, although there's the payment parity does not apply to that yet. So when you think about implementing telemedicine in your practice, what are the practical issues that you should be aware of? Well, number one, I think the biggest thing is actually the bullet point number 3 here, which is that telemedicine does not allow you to cut corners, right? You will be held to the same standards of care as if the patient was in person. That is the one takeaway that you should always have. So for me, seeing a sleep patient in the office and seeing a sleep patient virtually is exactly the same. I do almost the same physical exam. Yes, I don't, necessarily listen to their heart or lungs, but I do a pretty good upper airway exam and go through the same history and physical that I would otherwise. You have to have patient consent. You have to know about patient privacy. So I think it's important for patients to recognize that their privacy will be maintained, because they don't want to be thinking that you're in a, let's say you're home and family members are around. Super important to assure the patient that, hey, we're going to be maintaining privacy while doing this particular consultation. You have to follow all of the state regulations, and we'll talk a little bit more about that. It has to be in an electronic medical record where you're storing the information about the patient's visit, and it should be retrievable, just like any other visit. And you have to have clinical protocols and contingency instructions. So any telemedicine company you work with, just make sure that they have these protocols in place so that we don't run into any trouble. So having said that, I think many states, in 2017, for example, 40 states had adopted substantive policies that allowed telemedicine coverage across the US. And more private payers are adopting CMS standards. So people are getting paid for telemedicine. And in terms of sleep, the American Academy of Sleep Medicine is a strong supporter of telemedicine, right? This statement by the American Academy of Sleep Medicine position was done as early as 2015 and then recently revised. And basically they have a blueprint of what exact information we are supposed to be gathering from the patient during a telemedicine visit, what can be addressed and what shouldn't be. So this is something that, certainly in SleepMed RX, we're very familiar with and do follow all of those guidelines. The biggest barrier and I think fear that people have about telemedicine, certainly physicians I know have this fear, is are they going to run into regulatory issues, right? And I think it's, here are the basics. If you do a telemedicine consult, you have to be licensed in your own state. So if I'm in Minnesota, for example, I have to be licensed in Minnesota, and I have to be licensed in the state that the patient is being seen or is physically present in. So if I'm doing a consultation in Mississippi, I have to be licensed in Minnesota and Mississippi. So that is one of the reasons why I, for example, am licensed in all 50 states. So I can see patients anywhere in the US, and certainly SleepMed RX is structured so that we can provide telemedicine care anywhere in the US, which by the way, took some doing. There is some exception. So with Medicare patients, you can typically see them across state lines, even if you don't have licensure. But how long that's going to last is up for debate. And at least most states have not adopted those rules uniformly. So if you're a CMS patient, perhaps you'll get away with it. But if you are Blue Cross Blue Shield or or just going through state regulations, you do have to be careful about those. And then there's this issue of the corporate practice of medicine, which is as a physician, I cannot be employed by a non-physician. Similarly, a dentist, as you know, there are DSO setups and structures like that. As professionals, we have to be following the corporate practice of medicine laws as well. I'll just go through just a little disclaimer here. When we practice telemedicine, it is extremely important to recognize that not all malpractice policies cover telemedicine. So you have to have specific telemedicine coverage for practicing this. So many of the dentists now are adopting telemedicine into their own practice. And I would strongly encourage them to at least talk with their malpractice carrier and make sure that the telemedicine clauses are in place. Because certainly for us, we had to add significant writers and actually buy a new telemedicine policy to add to our current one. So that's just something that, as you start thinking about, because when we talk about telemedicine, it's not only physicians doing telemedicine with patients. Dentists are using telemedicine every day to follow up their patients and to maybe make adjustments on the dental devices. We'll talk a little bit about that as we go on as well. So,
hey, Doc, real quick, since you brought that up, I know we've got a couple of questions, and I can kind of sum them up in this one since you just referenced that.
Yep.
The differences between telemedicine and teledentistry are obviously, the different licensed professions, but dentists who are providers of dental sleep medicine are doing telemedicine consults for their sleep apnea patients.
Yep.
So would there, from your perspective, since you're a licensed physician that already does telemedicine, would they need to have additional writers or licensure on their malpractice for doing telemedicine consults as the dentist?
I would definitely check with their malpractice carrier. That is an absolute yes. Now, many of the malpractice policies do include telemedicine coverage, so that's the good news. But certainly there are policies that do not, and it is important to check with your malpractice carrier if you're doing any kind of telemedicine, for sure.
Got it. And the state-by-state questions, I'm going to leave because you're going there right now. So
Yeah,
I'll get out of your way.
Yep. So,
Cool.
I just put these up, not to go through them exhaustively, but just to sort of demonstrate to you that different states have different policies, right? So Minnesota, for example, is very friendly towards telemedicine. So you can see that there's laws, they allow live video, they allow store and forward or asynchronous telemedicine. They are part of a licensing compact. We'll talk about that in a minute. But there are other states that have different policies. So for example, in California, there is not payment parity. Remote monitoring is not allowed. In Connecticut, for example, you can't do store and forward or asynchronous telemedicine without specific exceptions. And so, these are the sorts of policies that you have to be very aware of as you're starting to do telemedicine. Now, the good news for us is that most states allow synchronous telemedicine that use audio and video, and that's usually not a problem. So again, in sleep medicine, we are sort of lucky. One of the good things that's happened is called compact licensure. So many states have banded together and said like, hey, if you have a medical license in Minnesota, we're going to make it super easy for you to get a license in all of the sort of dark blue states here. So instead of taking a 3-month, prolonged process to get another license, you can do that within a couple of weeks. And so on the medical side, that is certainly a big advantage. I'm not sure that is the case for dental practice, though. That's something, and I think, it's fair to say that for medicine, practicing across state lines makes a lot of sense because we don't necessarily do a hands-on fitting of a device, for example. So this may not be as relevant for some of you, but certainly for medicine, this is an advantage. All right, so we're going to go really super quick now because I'm just going to talk to you about how telehealth is used in sleep medicine specifically. And if you think about obstructive sleep apnea, for example, on this little right-hand side, you can do evaluation, you can do testing, you can communicate the results, you can do initial treatment care and chronic care management. So SleepMedRx, for example, has a contract with AmeriGas, which is a large trucking company, right? So we manage 6,000 of their drivers right from the time they are diagnosed, right through therapy, right through compliance with CPAP. So everything is done right on our platform through telehealth. And we'll talk about dental sleep in just a bit, but we can certainly treat patients with insomnia, both for consults and follow-up. Here's some data on patient satisfaction that was peer-reviewed studies, obviously double-blinded. And you can see that video visits and in-person visits, they have pretty much the same patient satisfaction and treatment adherence. And this was reported in the Journal of Telemedicine. Here's a randomized control study that looked at long-term sleep apnea CPAP management. And you can see here that there was essentially no difference, or there was no inferiority using telemedicine with monthly or 3-monthly follow-up in person. And I'm sure all of you dentists in the audience and myself too are chuckling at the tremendously low compliance numbers that you can see with CPAP. And I think that it's fair to say that another reason why I think it is so important for physicians and dentists to work together, because the sad truth is that 50% of patients don't use CPAP after year 1. So we must create those pathways for them to get into other forms of therapy. This is just a forest plot that looks at compliance in patients with obstructive sleep apnea and how, and again, using telemedicine. And this is, the reason I put this up is this is a large database with 2,500 patients almost. And you can see here that the overall data analysis actually favors telehealth compared to in-person visits when it comes to chronic management of CPAP. All right, another similar forest plot graph for compliance with CPAP. Cognitive and behavioral therapy can be administered for insomnia through telemedicine. I think one of the real values that I think we provide with telehealth is when we see a patient with obstructive sleep apnea, we can address some of the other issues. So I often am prescribing, medications for restless leg or talking about, sleep restriction therapy for insomnia and things like that, which I think are helpful as you start treating your sleep apnea patients, because there's so many other little issues that you want addressed. And that's pretty simple for us to do as we go across. And again, I'm just sort of now just showing you a few. There's a lot of peer-reviewed studies that basically show that telehealth is able to reach patients in a very cost-effective and compliant manner. So the last sort of focus of this conversation today is going to be about the sleep dentistry in particular and telemedicine, and why I think it's just a game changer, right? So when I was with SomnoMed, a long time ago, we had, a lot of, we used to do conferences where dentists used to come, teach them about the skills for sleep. And there was a lot of enthusiasm. People said, well, wow, we can actually change people's lives, which is true. You actually improve the quality of their life and their mortality when you treat sleep apnea. Extremely important. But the problem, of course, is that once you go back to your offices, you are really dependent on sort of local relationships, trying to figure out, hey, how do I send a patient to a sleep doctor and then not have them go on CPAP, or at least have them communicate back as to why and what happened. So, the enthusiasm, which starts really high, sort of drops off. And of course, getting paid is hard because of all the barriers of, you need to have a sleep test, you need to have it interpreted by a board certified doc, you need to have a prescription in hand. And so there's a lot of challenges and a lot of barriers to patients getting good care. And we were very, very aware of this. So, common obstacles, are there barriers getting patients with the right diagnosis? Do you think the cost of getting, diagnosed with sleep apnea is high? I mean, if you send a patient to a sleep physician and they do polysomnography, and that's a few $1,000s. Not everybody has that sort of money. And do you really need full polysomnography to diagnose obstructive sleep apnea? No, I mean, certainly not. So again, have you screened patients, send them to a doc, and now they come back with CPAP? And when we clearly they prefer dental devices. Have you been struggling with testing and screening workflow? All of these were obstacles that we were seeing. And I think on top of all of this, payers are making it mandatory now that, hey, you have to get a consult with a physician. You have to be able to get a prescription from a board certified doc, and it has to be on, you have to document all of this with a face-to-face encounter. So I think that the burden for dentists to be able to treat patients who are urgently in need of good therapy is actually a real barrier. So I think what we really have been focusing on is how do we decrease barriers for patients using technology, using sleep medicine, to create really seamless workflows. So that what I like to say is, if you screen a patient in your office, you should be able to get a prescription in hand in about 2 weeks. I mean, that is the workflow that we have really been refining and working towards. So, and I think, happy to say that we certainly are able to do that using technology. So how does this happen? Certainly using telehealth is key to this, right? So, if you can screen a patient, you should be able to get that patient evaluated with a telemedicine consult within a week. And certainly patients can have excellent sort of standard of care meeting all of the AASM guidelines doing this. We typically would discuss with a patient during the consultation what sleep apnea is, what the different therapies are, certainly talk about the treatment plan. And then if they, we can even use telehealth using the oral appliance treatment protocol. So plenty of dentists will see the patient in their office for the first visit, but then they do all of the titrations using telemedicine on the platform that we have. So a couple of just practical pointers as we see patients. One of the things is that you really should have audio and video backups. If a computer doesn't work, if audio is malfunctioning, important to have backup, because the patient obviously has spent their time and money to be on that platform. Important to center yourself and look at the camera as you're talking to people so that they're not feeling distracted. I often tell my patients, look, as I'm talking to you, I'm going to be typing and looking at your chart, but I always glance up so that I have that eye-to-eye contact as well. Important to look professional, right? This is important. Don't sort of move around too much. Good lighting, good location. Introduce yourself. So when I'm having a consultation, says, oh, so you've been referred by Dr. Smith, and my name is Dr. Bijwade. I'm in St. Paul, Minnesota. Where are you located? Having that sort of chit chat up front really puts them at ease, and that's something that's important for us. We talked about the eye contact. Have their consent. Say, is it okay for us to have this consultation on a telemedicine platform? We certainly, when they sign up for the consultation, we do have a consent form that is part of it. In terms of privacy, I think that if you have a home with other people, probably a good idea to have headphones so that other people can't hear the conversation. And I also tell the patients, look, nothing's going to be recorded, so don't worry about that. I am diligent about a focused physical exam. So I think when I started telemedicine, I was a little bit embarrassed to tell the patient, like, hey, open your mouth. But now I'm absolutely fearless. I'll say, hey, come close to the camera, open your mouth really wide, stick out your tongue, clench your teeth. And I really try and do a good, thorough exam. And I've even had patients sort of, change their lighting or go to a different place so that I can actually see the back of their airway. So, I think that, as we think about the future of telehealth, important to think about, will these reforms that the CMS introduced and that COVID accelerated, will that last for years to come? My suspicion is yes. Again, I think its patients will demand it. It's important to address the digital divide. We talked about some of the disparities. I think it's important to recognize that our whole infrastructure, right? The hospitals, the physician offices, the bricks and mortar is all based on a business model that is completely disrupted by telehealth. So, the economics of telehealth, I think, are going to be worked out over time. Yes, we save money, but what happens to people who have been relying, like hospitals, on in-person visits? How does all of that shake out in the long run? And then I think malpractice and cybersecurity are becoming increasingly large concerns. When we got our large corporate contract with AmeriGas, they really weren't worried about, whether we'll be able to take care of their drivers. That was a given. What they were worried about was cybersecurity. And they made us buy a really large insurance policy to cover for cybersecurity. So that was a sort of an interesting learning for us. So I think that, as we go further, especially with sleep telehealth, there has been a revolution because two things have happened. One is, of course, telemedicine, which we've talked about extensively now, but also the use of disposable home sleep testing. So in the past, we had to figure out the logistics of getting a device to a patient, getting the device back, uploading the studies, all of that. Now we have disposable devices. You can, give the patient a device or mail them a device, and they simply use it. There are devices that can be used multiple times, like the Night Owl as shown here, or the WatchPat Night 1 is a disposable as well. And when you, as a dentist, are able to do multiple studies with a single device over a period of time, guess what? You can now titrate the patient objectively, right? So you don't have to guess anymore whether the patient's obstructive sleep apnea is better. You can do it in a very controlled and objective way, again, leveraging technology for the home sleep test as well as telehealth. A lot of home sleep testing is now being auto-scored. There's a lot of wearables. So people are coming into offices. Certainly, we see patients every day that say, hey, doc, my Apple iWatch is telling me that I'm not getting any deep sleep or not having REM sleep. So those are conversations that open up and allow us to have those important sleep related conversations with patients. So,
Doc, if I could have you go back to that slide, just for clarity for the audience's sake.
Yep.
The Apple iWatch or
Yep.
Apple Watch does not diagnose sleep apnea. However, correct, the unit smaller than the watch that's on that fingertip is the Night Owl, and it can. Yes. So it's the footprint has drastically changed for what's out there on the market, as you were saying.
Right.
One of the
this is the Night Owl. So it's a little device that basically sits on your finger with a Band-Aid, and you can use it for 10 nights. So it really is making the diagnosis extremely simple and very accurate, by the way. So it's been validated against polysomnography. But I think the iWatch. Go ahead, Michael.
I've got a question here on the Night Owl, actually, okay, since you referenced it a little earlier. When you're using the Night Owl, and it is incredibly accurate based on all the studies, the channels that it's measuring, and you get a great looking report from it. When you're talking to a patient, do you ever come into the situation where they're like, I taped a Band-Aid to my finger, and now you're telling me that I have this life-threatening disease? Mm-hmm. How does that work?
Yeah.
Does that ever come up because of the footprint?
Well, not that specific question, but patients do ask, like, how accurate is this device? I mean, am I going to believe this result? And I think part of it is just explaining the technology. I think one of the things people are recognizing more and more now that we have wearables and all kinds of remote monitoring in place, people now understand that technology is really advanced, especially in the healthcare space. So I think that when we explain to them how peripheral arterial tonometry works and how the Night Owl is validated through the FDA, I think those anxieties can be pretty well allayed easily. Yeah.
Yeah. And on the multi-night part, could you speak to the value from your perspective as a sleep physician of the multi-night aspect of that particular device? I know you and I've had lots of dialogue about it. We don't have time to succinct that like in a nutshell for us here.
Yeah, and full disclosure, I'm one of the scientific advisors for Night Owl. But the reason I feel is such an important advance is that, especially in the field of dental sleep medicine, right? We all know that there's this individual variability in response. So once you have a baseline study and you start protruding the jaw, as we all know, that there's a certain sort of optimal position, right? Beyond which moving the jaw can actually be detrimental, right? Certainly in terms of side effects, but also in terms of the apnea-hypopnea index. So I mean, till now, when you advance and titrate a device, you basically were going with symptom improvement. Have you stopped snoring? Do you feel better? Are you feeling like you're more rested? Yep. Okay, let's do another study, right? That was sort of the model. And I think with the Night Owl, what you can do is you start in your, let's say, habitual bite or maybe 50% protrusion, whatever you're used to. But then as you're advancing the device, you can tell the patient, hey, I want you to use your Night Owl again on night 5 and 10, and I want to see whether the AHI is coming down. So now you're actually objectively following this patient with a little device that sits on their finger, so that there's this incredibly robust objective and subjective sort of follow-up for the patient, which I think makes an incredible difference in terms of how you manage them once they're titrated.
Cool.
Okay.
Awesome. Yeah, we got questions pouring in. I'll let you finish, and then we'll hop into the Q&A here pretty quick.
Yeah, so this is the last slide, but I just wanted to sort of walk you through what our current flow is for SleepMed RX, right? And just a brief, summaries. So basically, SleepMed RX is a medical practice, right? We have physicians and we have nurse practitioners that are licensed in multiple states and work through telemedicine. That's what we are, and we focus only on sleep. So we don't do, sore throats and anything else. We're just a sleep medicine practice, and we like to think that we're very oral appliance friendly because my background, of course, I've already talked to you about. But we only recruit people that believe in the same philosophy that we do. So I think that's a little bit of a differentiator. And how we think that the workflow works best right now is once you identify a patient as at high risk for sleep apnea in your practice. So you've screened the patient, they snore, yep, you're sleepy during the day. I think you could have sleep apnea. So you start that. Once you do that, I think that most people would agree that while the patient is in the office is the best time to schedule a consult, so that there's, you're not sending them out and saying like, hey, I want you to see Dr. Smith across the street who's a sleep doctor, and the patient leaves and they forget. No, you are actually going to schedule a telemedicine consult right before the patient leaves, right, on a platform. And within a week, we're actually seeing the patient, doing the consultation, educating them about the importance of sleep apnea, different ways to treat it. And at the end of the consultation, we prescribe a home sleep test, right? The home sleep test is completed, and within 48 hours, we're able to review the study and write the prescription that we've already talked to the patient about and return the patient to the dentist. So I think this is as streamlined a workflow as you can get. We do have the capability of managing the patient in other ways. So if a patient turns out to have very severe sleep apnea, we had a patient the other day who I saw who had a pacemaker, he had congestive heart failure, and he had failed CPAP 3 years ago, but he was also 340 pounds. And I told him, I said, you should not be on a dental device as your first choice, even if you failed once. Let's try CPAP again. We put him on CPAP. And so there are situations, and of course, we absolutely communicate this back to the dentist. That's the other thing. You have to collaborate. It's a team sport, right? There'll be patients that I can't manage that I want my dentist to help with, and vice versa. So I think that's the sort of practice that I think the future holds, and I've been super excited with the technological advances that have allowed us to do that.
Yeah.
So
well, Doug, I have to hop in here with one comment too. I think one of the fringe benefits that wasn't mentioned tonight in your presentation is that not just like every dentist isn't created equal, every dental practice isn't the same. Not all sleep practices are created equal, and telemedicine is a cool bridge where people all across the country can have access to you or your team and not respectfully be stuck with somebody who may or may not share the same operating structure. So that's a cool bridge. So if you're okay, we've got a lot of questions. And
let's go for it.
So the on the night owl, one of the questions was how does the night owl measure breath, and can it be reused for titration and the final sleep study without additional fees? I'll let you handle the breath answer. I'll answer the fee side, you guys. The titration tests can be utilized on the night owl without having a physician's read. But if you're talking about the final efficacy test actually being read by a physician, obviously that read is going to incur an additional fee at the very end. But go ahead for the clinical side of that.
Yeah, so very briefly, the way the night owl works is, when we have an apnea or a hypopnea, what happens is your airway constricts, your oxygen levels fall, and that triggers an adrenergic response, right? So your adrenaline and noradrenaline levels go up. That causes vasoconstriction, right? So every time your airway constricts, your oxygen levels fall, you get an adrenergic response, and your blood vessels constrict. So what we're measuring on your finger is the constriction of the blood vessel that occurs because of the airflow abnormality. That's how the airflow and the the vasoconstrictive signal are linked. And if you link that further to a drop in oxygen level, now you actually have the full spectrum. So you know that there was a stop breathing event, you know that there was vasoconstriction, and you know that the oxygen level fell. And that's how you diagnose sleep apnea with this device.
Cool. Awesome. Another, so complete 90-degree turn here. Will all medical insurance companies, including Medicare, accept sleep tests that are ordered via telemedicine without physician referral and face-to-face? So I'm guessing the question is, without a live physical contact consult, will telemedicine suffice for all payers in all states? And they specifically asked about Michigan. I'm guessing they're in the in that state. Go ahead.
Yeah, so we have not had any issues getting paid for home sleep tests from any company that we know so far with telemedicine. So no, there's no issue with that.
Cool. Autumn asks, does the patient know their consult fee in the practice prior to making the appointment? I can answer that on the dental side. Yes, absolutely. They have to know what the fee is walking into it. Okay, so we got a lot. I'm going to pepper you with these. What technology-wise, what technology requirements are there for performing the telemedicine consult, both for the patient and the doctor's office? Smartphone, computer, a Zoom account, like what's required there?
Yeah, so our platform is enabled for any device. So it could be a laptop, it could be a computer, it could be a mobile device, an iPad, doesn't matter. So we basically have the patient just log in with a username and password, hit a link, and they're on. So it's just like Zoom.
Got it. It sounds like my team needs to be on board for this telemedicine workflow. How would you recommend we train them? I'll pay whoever asked this. Could you share the last slide for our offer that we have?
Sure, absolutely.
So we're the course offer, you guys, is that we've got for you is our course with Awaken to Sleep. If you can see it here, we basically want to invite you guys to a 2-day event. If you like some of what we were dropping tonight, we do a lot more of that. We have a lot of fun. It's a Friday, Saturday course. The next one that's coming up is the 14th and 15th of May. So that's a week and a half from now. Because you guys have attended the webinar and we have that available. We've got limited seats, but if you guys want one, it's half off. So if you go to awakentosleep.com/events, that event for you guys is going to be 50% off. For the $297, you get 14 CEs and you get to invite 14 members. So it's doc plus 4, that's 5 people, 14 CEs each. And I have to tell you, Dr. Greg Manning, who is our co-presenter on that course, is stinking funny. So if you guys want some education on the workflow, the how-tos, that kind of thing, strongly encourage you guys go there. Thank you for the question and the shameless plug there. I'll get into a few more here. Dr. Bijwadia, back to you on this. Could you walk us through a brief outline of what you would go through with a dental patient who you're reviewing their HSC report? So post initial consult sleep test, you're talking to them about next steps. Let's say it's for oral appliance therapy. What does that conversation look like?
Yeah, I'll give you my spiel that I give my patients, right? So I say, Mrs. Smith, your sleep study confirms the fact that you have sleep apnea. And when we do a sleep test, what we're essentially doing is counting the number of times your upper airway is collapsing and causing your oxygen levels to fall. We classify it as mild, moderate, or severe based on the number of times your airway collapses. In your case, it looks like you have moderate sleep apnea. So let's say your apnea index was 14 or 18, something like that. And I would say that for patients with mild to moderate sleep apnea, there's a couple of choices. There's CPAP, which is a mask that fits over the face and pressurizes the airway from the inside. Dental devices are like a mouth guard that gently move the mandible forward and passively open up the airway. Dental devices work great for patients with mild to moderate sleep apnea, and oftentimes patients sort of stick with it better just because it's more comfortable. You do need to see a dentist that is trained in dental sleep medicine so that, they're able to do that for you. And also it's important for us to do a before and after study to make sure that the dental device works. But in the long run, dental devices have been shown to be as effective as CPAP. Certainly for severe sleep apnea, I would say that CPAP is a better choice as an initial. However, there are many patients with severe sleep apnea who can tolerate CPAP or prefer a dental device, and that's okay too. So that's sort of the, a 2-minute spiel that I would give the patient, and then answer their questions from there.
Awesome. Any feedback on your case acceptance? I know that's more of a dental word on the business side of the house, but how many patients do you get that look at you and say, yeah, I don't think so? Or they just do what you say? Like, do you have the magic wand?
I have to say that, once a patient comes through for a consult and does home sleep testing, we find that they're pretty committed. And I just haven't had patients that are, go through the process and say, oh, now I'm just not going to do anything about it. It's just not that common. So I think that, we do emphasize the risks of untreated sleep apnea. I go through the physiology of sleep apnea with the patients. And by the end of it, I think, just like in my practice, we just don't have that sort of, they might sort of waver between what treatment they want, that's for sure. But whether to treat or not, no, I think they usually go forward.
Got it. Joseph's got a question. Can an insurance company demand a trial CPAP or a CPAP trial, even if a physician prescribes an oral appliance?
Yeah.
Yes.
So that's a good question. The answer is yes. Very, very few insurances actually do require that. There's a company called AIM that sometimes has, certain Blue Cross Blue Shields require that. But I have to tell you that we are happy to write peer review letters. And we certainly have to, with every prescription, we always write a certificate of medical need. So when a dentist has a prescription, they have our CMN right with it.
Right.
And so, yeah, it's obviously we're aware of that, but we're happy to fight with the insurers.
Awesome. Yeah, sometimes that needs to happen. That's for sure. Okay, scheduled for their appointment. Oh, what is the ideal setting for a patient when you do a telemedicine consult? Is it in their house? Is it them coming back to the dentist's office? And I guess we could parlay that into another question, which is no-show rates, even if someone's committed or paid for the visit. So ideal setting and how to avoid no-show rates. Let's put those two together.
Sure. So on a typical, I would say that the no-show rate is less than 10%, less than 5% even. So out of 100 patients we see, maybe 5 don't show. I think that's partly because they've been prepped and they've paid, right? So it's unusual for somebody not to do it. In terms of where to do the consult, I think it depends on the patient's schedule. But I would say 95% of our consults are done with the patient either in their home or their office or even in a car. They just whip out their phone, stop for a few minutes and do that. So we've seen all flavors. Now there's no problem doing a consult at the dental office. The hard part is the scheduling. Making sure that you have that schedule aligned. That's a little bit harder to do. Got
it. But if they're doing it on checkout, like what you mentioned, they've got the patient in front of them, that gets scheduled at the same time they have a window or a column
and
open.
So far, we are able to schedule patients, I'll say within 2 to 3 days. So we don't have long wait periods. I mean, if it takes more than a week to schedule a consult, and maybe the no-show rate would be higher, but we typically see patients within 48 hours. So it's pretty quick.
Awesome. Okay. Time frame. Okay, you already hit time frame for receiving the RX. Post consult, that's so let's say the consult happens. At what point should the dentist's office expect to have your chart notes and prescription, that kind of thing?
Yep. So once the consult happens, we wait for the home sleep study to be done. We typically do 2 nights of testing. And usually within 48 hours of the sleep study being done, the report is back in with a prescription. So I would say pretty realistic to think that a week after this consult is completed, you would have all of the documentation and the prescription in hand.
Gotcha. And does that, the prescription and the letter of medical necessity, does that also include the chart notes automatically from the consults?
Yep. So you can download the chart notes whenever you want. Absolutely.
Got it.
And
Cool.
also, I mean, I do want to emphasize that, you know, if a patient does require other forms of therapy, we do arrange that. So we have nationwide collaboration with, you know, with other therapies as well.
Got it. Awesome. Well, we are almost 10 after. So we are on, we'll call this on time for today, especially given the amount of questions that we had.
Yeah.
So since we're past the time from a CE requirement, guys, just a reminder, there are 2 links in the chat right now. One, you can go to the survey for your CEs. You want to get those CEs, again, 37.2 seconds to finish your survey. It's not long. The second link is for the upcoming course. If you guys want to go deeper into dental sleep medicine, you want to have some fun on a weekend, click that link, get your ticket. Last thing, if you want to see Dr. Jagdeep again, you can schedule a consult directly with him at sleepmedrx.com. If you're a dental office looking to integrate this into your practice, Awaken to Sleep would love to help you. We work with Jagdeep and many of his colleagues. So we'd love to get you guys connected with a workflow that makes sense for your practice and connected to their providers. So thank you guys for your time. Doc, any parting words to sound off here?
Listen, I love working with dentists, so this is great. And I would love for the audience, if they want to connect with me on LinkedIn, just, you know, keep in touch. Any questions, always here to help.
Cool. Awesome. Well, thank you, Doc, for your time tonight. We hope you guys have a good rest of your evening. And you will get an email, last thing, so my team doesn't kill me. You will get an email by 7 o'clock Pacific time. That is 52 minutes from now. If it's not in your inbox, it's in your spam box. Hit that before you hit a support ticket. We appreciate you guys. Have a good night.
Bye-bye.